Hello, everybody. Welcome to our weekly meeting. Today we have a very interesting topic, sudden cardiac death risk assessment in hypertrophic cardiomyopathy. And the conference will be taken by Dr. Berrani from our department. And Borahla isn't here, so you can start the conference, and after that we will have an interesting discussion about this topic. And Berrani, تفضل.
Thank you, Professor Bonkhada, for this introduction. So today we are going to present you with an important topic, which is that of sudden cardiac death in hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is a common disorder of cardiac muscle associated with sudden cardiac death, with an annual incidence of cardiovascular death of 1 to 2%, mainly caused by ventricular arrhythmias. Sudden cardiac death can be effectively prevented by Icd therapy. Therefore, the identification of high-risk patients is of a huge importance. Let's start with a clinical case. A 25-year-old female patient comes to our department for progressive shortness of breath for the past 6 months. She had no personal medical history. The physical exam was normal. Lab tests were normal. This is her EKG that shows normal sinus rhythm, left ventricular LVH, and asymmetrical septal hypertrophy with profound dagger-shaped Q waves in the inferolateral lead. The transthoracic echocardiography, this is a personal long axis view showing asymmetrical septal hypertrophy with small left ventricular diastolic diameter. This is a personal long axis view. The left atrium anterior posterior diameter is 41 millimeters. This is a personal short axis view. We measured the left ventricular wall thickness in different segments. The left ventricular hypertrophy is predominant on the interventricular septum and the interior wall, with a maximal left wall thickness of 30 millimeters. The left ventricular ejection fraction was normal, 67%. The left atrium was dilated in volume with an indexed volume of 36. This is the LVOT gradient at rest. It was 28 millimeters of mercury, and after provocation with Valsalva maneuver, the LVOT gradient increased to a value of 49 millimeters of mercury. This is a both eye representation of left ventricular strain that shows a marked alteration of strain in the interoceptal, inferoseptal, and to a lesser degree in the interior and inferior wall. An ambulatory 48 hours ECG was performed in this patient and showed no ventricular arrhythmias. What is your diagnosis? By now, most of you would have guessed the correct diagnosis. So in adults with the hypertrophic cardiomyopathy, which is defined by a wall thickness that is higher than 15 millimeters in one or more LV myocardial segments, as measured by any imaging techniques, transthoracic echocardiography, CMR, or CT scan, that is not explained by abnormal loading conditions. In patients with a family history of hypertrophic cardiomyopathy, the cutoff value is lower, which is that of 13 millimeters. In children, the left ventricular wall thickness should be higher than 2 standard deviations. So our patient has obstructive hypertrophic cardiomyopathy. Now, how to assess sudden cardiac risk sudden cardiac death risk in our patient according to the USC guidelines. According to the USC guidelines, it is recommended that the 5-year risk of sudden cardiac death be assessed at the initial visit and periodically every 1 to 2 years, or when there is a change in clinical status. The 2014 USC guidelines has come up with a novel calculator that allows us to estimate risk of sudden cardiac death at 5 years in patients who are aged more than 16 years old, and it is a class 1 recommendation. For secondary prevention in patients who have survived sudden cardiac death or who have had malignant ventricular arrhythmias, the implantation of an ICD is a class 1 recommendation. The latest USC guidelines recommend the use of a novel sudden cardiac death risk calculator, which is derived from clinical history, transthoracic echocardiography, and 48-hour ambulatory OCG. This calculator is made of 7 parameters, 3 of which are derived from echocardiography. Once the risk is calculated using this calculator, patients are stratified into 3 categories. High risk category, when the estimated 5-year risk is higher than 6%, an ICD should be considered. The intermediate risk category, where the ICD may be considered, and the low risk category, where the ICD is generally not indicated. Now let's assess the sudden cardiac death risk in our patient. Our patient was aged 25 with a maximum LV wall thickness of 30, left atrial size of 41, maximal LVOT gradient of 49. She had no family history of sudden cardiac death, no non-sustained VT on ambulatory ECG, and no unexplained syncope. I have already done it for you. The risk of sudden cardiac death at 5 years for our patient is 3.81%, which falls into the low risk category. For patients in the low risk category, the ICD is generally not indicated, but sometimes it might be indicated if there are other risk factors of prognostic importance, such as the presence of multiple young sudden deaths in family, or an abnormal exercise blood pressure response. The calculator proposed by the latest USC guidelines has some limitations to it, as it cannot be used for pediatric patients aged less than 16 years old, elite competitive athletes, hypertrophic cardiomyopathy that is associated with metabolic disease and syndromes, or in patients with severe LV wall thickness higher than 35 millimeters, as the risk in such patients has a tendency to diminish. What about risk assessment according to American guidelines? To the left of the screen is an algorithm that I borrowed from the 2011 American guidelines, and to the right of the screen is the latest algorithm that I borrowed from the latest American guidelines 2020. For secondary prevention, nothing has changed. Patients who have survived sudden cardiac death or who have sustained malignant ventricular arrhythmias, they have a class 1 indication for an ICD implantation. For primary prevention, there has been some modifications. Family history of sudden cardiac death, massive LVH, unexplained syncope are still considered as major risk factors. Apical aneurysm and ejection fraction has been upgraded to major risk factors, as they were considered before as risk modifiers. There is an important modification to mention is abnormal blood pressure response that was omitted from the latest American guidelines on sudden cardiac death assessment and prevention. Now let's assess the sudden cardiac death risk for our patient according to the US, to the American guidelines. Our patient hasn't sustained sudden cardiac death or any malignant ventricular arrhythmias. Our patient has no family history of sudden cardiac death, no unexplained syncope, no apical aneurysm, and no systolic dysfunction. But our patient has a massive LVH with a maximum LV wall thickness of 30 millimeters. Massive LVH is defined by a wall thickness higher or equal to 30 millimeters as measured by echocardiography or CMR. There is an important remark to be made here. For the USC calculator, the LV wall thickness is measured by echocardiography and not by CMR, even though echocardiography has a tendency to underestimate LV wall thickness. So our patient has massive LV wall thickness, which falls into this category. She has one major risk factor, which makes her eligible for an ICD implantation with a 2A indication according to the American guidelines. Now let's make a quick comparison between the American and the European risk assessment methods. To the right of the screen is the European risk calculator, and to the left of the screen is the latest algorithm derived from the latest American guidelines. The European risk calculator takes into consideration age, left atrial size, and maximum LVT gradient, which are not included in the American sudden cardiac death risk assessment. There is an important difference to underline is maximum LV wall thickness in the European risk calculator. The maximum LV wall thickness is a continuous value. Each value of LV wall thickness has some degree of risk to it, as opposed to the American guidelines, where the LVH is a binary value. So patients who have a left wall thickness higher than 30 millimeters are considered as a risk factor, and those who have a left ventricular wall thickness less than 30 millimeters are not considered is not considered to be a risk factor. Now, which risk score is more reliable, and which one should we use in order to assess sudden cardiac death in our patient? As we have noticed, according to the European guidelines, the patient falls into a low risk category, and according to the American guidelines, the patient has a 2A indication for an ICD. So the Tufts HCM Institute study tried to answer the previous question. This study included 2,094 patients who were, and this study concluded 2,094 patients, and they were assessed for sudden cardiac death risk using the American risk factor strategy with one or more major risk factors. 527 patients were identified as high-risk patients and implanted with an ICD. Among the patients who were implanted with an ICD, 82 have had life-saving ICD shocks, which corresponds to 16% of which corresponds to 16% of all implanted patients. 5 persons of those of all the patients who are not implanted with an ICD have sustained sudden cardiac death, 2 of which have declined an ICD implantation, even though it was proposed for them. Two of these patients had no risk factors, and one was not advised for an ICD implantation. The American risk factor strategy has proven to be highly sensitive, as it allowed to identify nearly all at-risk patients. The USC risk calculator was retrospectively applied to these patients, and 50% of them were considered as low risk. So many patients would have died if we used the USC risk score. So, as a conclusion, the USC risk score is less reliable and less sensitive than the established American risk factor strategy for identifying candidates for ICD in a heterogeneous disease such as hypertrophic cardiomyopathy. The best way is the clear and concise method using one or more of the established individual major risk factors. So for our patient, we decided to implant an ICD and follow the American guidelines, as they allowed to save more lives. Now, what should we propose for our patient? A single versus a double chamber ICD. So most patients require only a single ventricular lead. Exceptions are made for patients who have an LVOT obstruction, who will need an atrial lead in order to be able to provide the option for a short auriculoventricular delay pacing. So our patient should receive a double chamber ICD with a short auriculoventricular delay pacing. Now, how about risk assessment in children? The risk assessment in children is much more challenging, as all of the conventional risk factors have been derived from studies conducted on adult patients. Nevertheless, the USC guidelines recommend an ICD in secondary prevention in children who have survived a cardiac arrest or experienced documented sustained ventricular tachycardia. For patients, for primary prevention, an ICD implantation should be considered in children with 2 or more major pediatric risk factors. There are 4 major pediatric risk factors, which are unexplained syncope, family history of sudden cardiac death, that is defined by 1 or more first-degree relatives with sudden cardiac death who are aged less than 40 at the time of death, with or without a diagnosis of hypertrophic cardiomyopathy, or at any age with an established diagnosis of hypertrophic cardiomyopathy. Maximum LV wall thickness defined by a value higher or equal to 30 millimeters, or a Z-score higher or equal to 6. And non-sustained ventricular tachycardia with more than 3 consecutive ventricular beats at a frequency of higher than 120, lasting less than 30 seconds. Now, in the presence of only one of these major risk factors, an ICD implantation may be considered, and it's a 2B indication for ICD implantation in children. What about risk assessment for children in the American guidelines? There are no major differences between American and European guidelines as far as risk assessment in children is concerned. So for children with hypertrophic cardiomyopathy who have 1 or more conventional risk factors, including unexplained syncope, massive LVH, non-sustained VT, or family history of early HCM-related sudden cardiac death, an ICD placement is a 2A indication. In patients, the American guidelines recommend the use of late gadolinium enhancement and systolic dysfunction in the risk stratification process in patients whose risk remains uncertain. Sudden cardiac death prevention is an integral part of the management of patients with hypertrophic cardiomyopathy. More research needs to be done in order to improve the performance of existing sudden cardiac death risk scores in identifying high-risk patients. Thank you.
Thank you, Berrani. Thank you for a nice presentation. Is Dr. Burhala here? I don't know. Are you with us? I don't know. If everyone has a question or comment, Dr. Mouzawi, you have a question? Unfortunately, we haven't a case, clinical case. Dr. Amrouche, you can ask a question if you want.
Thank you. You show clearly for us the difference between the European and American score for the sudden cardiac death. So which one will you choose in your practice? Because it's really hard to choose between the two of them, and maybe with the evolution of the trials, maybe it will be another score, another European score for sudden cardiac death in next year. So which one will you choose in the practice?
You mean in clinical practice?
Yes.
Berrani.
Well, in the light of the presentation I just made, I would go for the American guidelines as they are more flexible and they have proven themselves to be very and highly sensitive in identifying high-risk patients. In the study I just presented, the American guidelines allowed the identification of near all patients who have sustained a cardiovascular event, and most of the deaths were prevented. If we use the USC risk score, many of these patients would have died as they were classified as low-risk patients. This is the case of our patient. When we use the USC risk score, which was 3.81%, it falls into the low-risk category. But when we use the American guidelines, it has a 2A indication. Now, which one to choose? Should we leave the patient without an ICD and follow the USC guidelines?
Excuse me. Can you show us the slides? Can you show us the slides
yes,
again?
Of course.
2 slides.
So in this study, I'll just go over it quickly. This study it's a very important study because it allows us to pick one over another. The Tufts HCM Institute study, what did they do in order to answer this question? They wanted to know which risk score is more reliable. So they included 2,094 patients into their study, and they used the American risk score assessment, which means the presence of only one risk factor. The patient was proposed for an ICD implantation. So 527 patients had an ICD. After a period of follow-up, 82 patients of the 527 patients who were implanted with an ICD have had a life-saving ICD shocks. And in the population of patients who have been excluded from ICD placement, only 5 patients have had sudden cardiac death, which means that the American risk score has allowed us to avoid 82 deaths out of 87 because if we the number of patients in this study who have had cardiovascular event was 82 who have been saved by the ICD shock, and 5 patients who have died because they didn't have an ICD. And now what did they do? They retrospectively used the USA risk score on these 82 patients in order to assess the performance of the USA risk score, and almost 50% of the 82 patients were classified as low risk according to the USA risk score, which means that if we used the USA risk score for these patients, many of these patients would have died because of the low sensitivity of the USA risk score in identifying high-risk patients. So in clinical practice, I would go for the American guidelines as they are more flexible and highly sensitive.
Thank you. Bruce, are you satisfied with his answer? I think it was clear, no?
It's clear. It's more sensitivity is superior for the American one, but it will have a cost. You will
of course.
more ICD in HCM patients.
Sure.
But I don't know this study if it was prospective or retrospective, because the ST risk score they did it retrospectively after the patients who were under the ICD and after the follow-up.
This study was a prospective study. The USA risk score was retrospectively applied on these patients in order to assess its performance. But the original study, it was a prospective study where they included 2,094 patients and they assessed them for ICD, and they indicated ICD in placement for 527 patients, and they followed them, and they noticed that 82 of patients who were implanted with an ICD have had life-saving shocks, and only 5 patients of those who didn't have an ICD had sudden cardiac death.
Thank you. Jamal has raised his hand. You have the floor, Jamal.
Yes, hello everybody. So I have 2 questions for Mr. Berrani and our attendants. Especially when we're talking about HCM, it's a very foggy topic. And speaking about the comparison between the ESC and HAA, we know that every society, every cardiac society is about to complement herself and say that their criteria is better. But the topic generates much discussion. And my question is, can we apply the American score in our population, knowing that the Caucasian male, white male that were included in this study, the genetics are far more different from over the continents? And my second question is, what about the late ventricular potentials used in the vectograms? Are they any of use? I know that my question is very ancestral and ancient, but I want an answer. And thank you for the presentation. It was an excellent presentation. Thank you.
Berrani.
Yes. So for the first question, concerning whether
applying the recommendations, I think is very difficult and very expensive.
The American recommendation to a Mediterranean population is a good choice. I think that we can use either USC or American guidelines alike, and I don't know of any. I don't know of any limitations to its use on the Mediterranean population. maybe our HCM expert, Dr. Bahla, has more light to shed on the subject.
Don't you think that it is very expensive to apply this recommendation? And it's
well, one of the advantages of the USA risk score is that it limits the overuse of ICDs, as it allows an accurate identification of low risk patients, but it has a weak sensitivity of identifying high risk patients. But at the end of the day, only 6 ICDs allows us to save only 1 life. It doesn't matter whether we use the USC or the American.
Okay. German has the floor. She raised her hand. German. Okay.
Vous m'entendez?
Yeah.
Do you hear me?
Yeah.
Berrani, thank you for your presentation. Just one question about the gadolinium enhancement. Do you take into account the quantification of fibrosis? Often it's not clear in the reports of the person who had performed the MRI. So in heart failure, we take into account this the percentage of 20%, the threshold of 20% to indicate the ICD. What about HCM? Second question about the study about RESET HCM, which has proven that a moderate daily exercise can perform results about sudden heart death, sudden cardiac death. So how do we manage? Do we have to first score the persons, then indicate or no the ICD, and after that we can start rehabilitation, heart rehabilitation program, or we can do it without scoring the patient? How do we manage this? How do we use the result of this study?
So concerning the first question about the interest of late gadolinium enhancement in the sudden cardiac death risk assessment, so the American guidelines consider late gadolinium enhancement on CMR with a cutoff value of higher than 15% as a 2B indication for the placement of an ICD. And we perform a CMR with late gadolinium enhancement in patients who don't have any of the major risk factors, and in cases where the sudden cardiac death risk assessment remains uncertain. So we perform CMR as it allows us to measure, to look for left ventricular apical aneurysms, which can be missed by transthoracic echocardiography, and have a precise assessment of LV systolic function, as well as late gadolinium enhancement. The presence of late gadolinium enhancement with a cutoff value of 15% of LV mass is a 2A indication for an ICD placement.
Okay.
So for the second question,
Yeah.
I think it was about
RESET HCM.
It was about the practice of sports in patients with hypertrophic cardiomyopathy.
Not the practice of
Am
sport.
I right?
No, not the practice. The interest of daily practice, moderate exercising. It has proven that it was good for patients, but do we have to score them first, then look for an ICD or not, and then rehabilitate them, or we can start the two strategies at the same time?
Well, most patients,
it was good for patients, moderate daily exercising.
Well, most
kind of readaptation.
Most patients with sudden cardiac death, it generally occurs at rest. So the majority of deaths in hypertrophic cardiomyopathy occur at rest. Nevertheless, patients are advised against the practice of competitive sports or intense activity. It is a class 1 recommendation. Now, for patients, for patients with who practice moderate physical activity, it is not a counterindication, and they are managed just like the rest of patients.
Thank you, Berrani.
Burahla, our expert, is here. Do you want to say something?
Yes, good evening, everyone. I couldn't connect when Berrani was presented this topic, but I can I want to ask about this good study, Tufts HCM study. The American are more aggressive than European in the indication of the implementation of ICD. But in this study, we want they save 82 lives, but we want to know how many people are implanted, but they don't have shock, have been implanted with the risk factors, but they don't have shocks with their ICD. That the imbalance between appropriate shocks and patients who can benefit from the ICD and the patients who can have the implantation, but they don't use it. And the second.
Okay, well, in this study.
Yeah.
Okay, go ahead, Dr. Bahla, go ahead.
Yeah, the second remark about people or children who with the American guidelines, they insist about the discuss with the parents about the indication of implantations, the ICD, ICD implantations. But when parents are not agree with the implantation of the ICD, and their children want to practice sports, even competitive sports, we know that the ICD is not the indication for the practice of sports. They insist, the American people insist about this, but the sport can produce or could produce more shocks, inappropriate shocks. How can they manage, how they explain that? Could explain that?
Well, concerning I'll start with the second question. The American guidelines have two class 3 counterindications for an ICD placement. The first is ICD placement in patients who have no major risk factors and who are not at high risk. And the second contraindication is in patients whose sole indication of the ICD is the possibility of participation in sports competitions. So it is a class 3 recommendation. In young patients, especially those who practice sports, as you just said, the frequency of inappropriate shocks is higher as they are more active, and that's it. Now let's go to the first question. That the American guidelines fall into ICD overuse as they implant more patients, and are these implantations justified? So let's go back to our study. So in our study, 527 patients out of 2,094 patients were considered at high risk, and they benefited from an ICD implantation. So among these patients, 82 patients have had life-saving shocks, which corresponds to a percentage of 16%. So 16% of all the patients implanted with an ICD were saved from certain death, which is a good bargain. If we divide 527 on 82, we find a ratio of 6 ICDs for 1 life saved, which is a very good bargain. And if we take a look at patients who haven't been implanted with an ICD, it's just a very small percentage of 0.3% of those who have had sudden cardiac death. That means that the American risk score has allowed the identification of nearly all of the patients who have had cardiovascular events. I think I just answered the question.
Okay, thank you for the audience say to please show us again the slide of American algorithm. Can you show us again the slides? It's very interesting slides. Okay, this one. You have a question, Amrush, about this slide,
Yes.
huh?
Yes, I just wanted
or
to know.
Jamal. Okay, go on, Amrush, go on.
Okay, thank you. Just wanted to know if there is some limitations, like in the European one. I mean, the ESC score can be applied in children populations and the other limitation that Berrani showed to us before. And for the American one, I just wanted to know if it's the same, if we can apply it in children population and other issues. Thank you.
Thank you, Amos, for your question. Well, for this algorithm,
can we apply this algorithm to the children, for example, or is it specific for the adults?
Well, the question was is there any are there any limits to the American guidelines as there are for the USC guidelines? So the American guidelines, let's go back to the definition. The definition, the American definition of hypertrophic cardiomyopathy excludes infiltrative diseases, excludes syndromes. It is only limited to sarcomeric form. So these algorithms allows us to predict sudden cardiac death in patients with sarcomeric hypertrophic cardiomyopathy.
Right. Yeah.
Now it cannot be used. It cannot be used in patients aged less than 16 years old. Even American algorithm cannot be used in this. As in these patients, there are only 4 major risk factors that I just mentioned earlier that can be used for an ICD placement. Now, for patients with massive LVH, there are no limitations because all of the patients with a value higher than 30 are considered as a single factor. It doesn't matter whether it is a 30 millimeter or 40 millimeter. It is considered as just a major risk factor.
Okay.
Well, I think I just
yeah. Maybe Bilal, you have a Bilal Jamal. You have go on.
Yeah,
if you
I have,
if you have
I have
question,
one
go on.
comment. I have one comment about exercise that Dr. German and Dr. Borhla spoke about. In children, there is a position paper in the ESC that speak about phenotypic positive and genotype positive children that wanna pursue competitive sport or an athlete career, and they did specify that these children we cannot limit their exercise, but we should monitor their exercise by monitoring on echographic settings and the cardiopulmonary exercise testing, especially the measure of the VO2 max, the peak oxygen uptake, and it's just a monitoring. The children, they don't implant ICDs but they monitor children phenotypic positive, genotype positive, phenotype negative. There are no limitations, and children are seen in a very long monitoring setting. And Berrani, please, you didn't answer my second question about the ventricular potentials, the late ventricular potentials. On the vectogram, are they of any reference today? Are they still trendy or not? Thank you.
Okay, Berrani.
Well, they don't have any interest anymore in the most recent guidelines, either in American or European guidelines.
Thank you.
And what about late potential? Lamia, Borhla, do you have
Yes,
do you have the answer?
Yes, for late potential was used in ischemic cardiomyopathy as and it was a risk factor for ventricular arrhythmia, but in the last years they cannot use it as they was use it before. Because there is other how can I say other factor risk are more consistent for the risk of arrhythmia. And when they indicate the ICD for the prevention of sudden cardiac death, they use a difference between sudden cardiac death and ventricular arrhythmia. There is not a strong correlation in this time.
So Borhla, you mean that this parameter is definitively abandoned, or what?
Yes.
To stratify
yes.
the risk. To stratify the risk.
Yes, it's they don't use it actually.
Okay. Amrouche, go on. You raised your hand.
Yes, sorry, Berrani, I asked you a lot today, but it's really interesting what you presented on this topic. I just want a little question about unexplained syncope. What does it mean when they say unexplained? Because it's really hard sometimes on patients. They have some syncope, but is it an hemodynamic one because of the obstruction, or is it because of arrhythmia? It's hard to make difference between the etiology of the syncope.
Berrani.
Well, thank you, Amrouche, for your question. Unexplained syncope means that syncope that is not due to alveolar obstruction or vasovagal origin.
Good. It's that's why we use the term of unexplained syncope. it means that the syncope probably was related to the ventricular arrhythmia. And
but
not,
how can we be sure?
yeah, for example, patient who underwent syncope related to LVOT, they have the syncope, effort syncope, for example. That's why we make correlation between syncope and effort. It's probably related to LVOT.
Okay, thank you.
So the context of the syncope, we use the context of the syncope.
When syncope happen at rest, it's in favor of arrhythmias.
Yeah.
Okay, thank you.
You're welcome.
Have you another questions or comments? Everyone? No? So we will finish this interesting meeting. But before ending this interesting conference, I want to congratulate Dr. Berrani for his very clear topic conference. And I want to congratulate congratulations for our new professor who passed the exam and with success, Dr. Professor Ait Mukhtar Omar. And you hope and owe you, inshallah, a good meal. We look forward to seeing you next week, everybody. We have two conferences on the same day. You have note that we have two conferences on the same day on 3 February. We have one at noon on cardio-oncology by our colleagues from Marseille, from Mediterranean Center of Cardiology Oncology. Very interesting conference about what is the name, Absalam? Remind me of the conference of our guest, Kotela, Dr. Kotela, maybe. Ait Mukhtar.
Yes, yes.
Kotela.
Jennifer.
Okay. Jennifer Kotela, it's specialist in on cardio-oncology, and I think the director of the Mediterranean Center of Cardio-Oncology in Marseille, in France. And the second conference will be at 6 p.m. and the topic is on echocardiography in pulmonary hypertension by Vacchiari, I think, Professor Vacchiari from Erat Hospital. And so if you haven't any comments, take care of the patients and take care of yourself and protect yourself, and looking forward to seeing you next week.
Monsieur Boukhada, vous m'aviez la dernière fois chargé de présenter une question.
Okay, it's good. If you have a question, it's good. It's good.
Donc,
it's good.